Hello, and welcome to the Health is Fluid webinar series hosted by ImpediMed. My name is Joanne Yao, and I am the Senior Director of Marketing for ImpediMed. Today's webinar is about reimbursement strategies to increase patient access to L-Dex technology. The L-Dex lymphedema assessment is a validated metric for the detection of lymphedema that is tested using the SOZO device. SOZO is a non-invasive 30-second test that provides the L-Dex score, which is a measure of the fluid buildup in a patient's limb. When used as a part of a program for early detection and intervention of lymphedema in breast cancer patients, L-Dex has been shown to reduce lymphedema progression by 95%. Based on popular demand, we are focusing today's discussion on reimbursement for L-Dex technology. We have two powerful speakers. First is Chelsey Jaworski, Associate Director of Payer Relations at MCRA, who will discuss billing details. Second, we have Dr. Pat Whitworth, breast surgeon from Nashville Breast Center in Tennessee, who will discuss how he implements SOZO with L-Dex in his practice. We encourage you to participate by submitting questions via the Q&A icon on your screen. At the end of the presentations, we will answer as many questions as possible. We will also follow up on any questions that we're not able to address live during today's session. So without further ado, I will turn it over to Chelsey.
Good afternoon. My name is Chelsey Jaworski. I'm the Associate Director of Reimbursement, Health Economics and Market Access at MCRA. Today we're going to be discussing the patient access program for the SOZO Digital Health Platform utilizing the L-Dex technology and how we're helping patients and providers gain access to the appropriate care. MCRA is a leading medical device and biologics CRO with integrated clinical, regulatory, reimbursement, and quality services. Today's presentation objectives include understanding the CPT code 93702 and increasing patient access to the L-Dex technology. CPT code 93702 is a Category 1 code. The code description reads as bioimpedance spectroscopy extracellular fluid analysis for lymphedema assessment. It has an established Medicare national physician payment of $140.75, while the Medicare hospital outpatient payment is $138.35. Indications for use for this technology is for adult patients who have lymph nodes from the axillary and or pelvic regions either removed, damaged, or irradiated. Common questions about CPT code 93702 have been received from physicians, providers, patients, and even the payers. And we're going to go over these common questions over the next couple of slides. What are the applicable diagnosis codes typically used in conjunction with L-Dex? There are no specific diagnosis codes and or ICD-10 for L-Dex. Providers may use a diagnosis code of underlying disease, such as breast cancer or lymphedema. It is up to the provider to state the best primary diagnosis and secondary diagnosis for their particular patient. Some payers may have policies requiring the use of a particular diagnosis code for L-Dex when submitting your claim. They are outlined in the payer-specific medical policy for bioimpedance spectroscopy. What type of healthcare provider can perform the L-Dex procedure? So CPT code 93702 doesn't have any physician work RVUs or relative value units. Therefore, trained personnel such as a physician assistant, medical assistant, physical therapist, or RN can perform this test. A very common question is, can a physical therapist bill CPT 93702? It is recommended that the provider should contact their payer directly to confirm that the CPT code is an approved code under the physical therapy contract. If it is an approved code, then yes, the physical therapist can bill for 93702, but we highly suggest that you confirm with your payer's contracting. Physical therapists practicing in an independent rehabilitation facility should also contact the payers to pursue adding the CPT code 93702 as an allowable service. Is there a relative value unit or RVU related to the review of L-Dex results? CPT code 93702 does not include a relative value unit for the physician work. However, the physician can bill an evaluation and management code or E&M service to account for the work portion of the service. For example, the physician can bill CPT code 99212, 99213, 99214, or 99215, their evaluation and management code, along with the 93702. It is recommended that you put a modifier 21, modifier 25 onto the E&M code if billed on the same day as the 93702. Which payers cover the L-Dex technology? Currently, the Medicare administrative contractors will provide coverage for the procedure as long as they deem it medically necessary. All providers should be submitting claims to each individual MAC jurisdiction in your area, as the claims should go through as medically necessary as long as you provide supporting documentation to support the medical necessity claim. Additionally, commercial payers that do not currently have a medical policy on bioimpedance spectroscopy claims can be submitted. You can contact MCRA, and MCRA will provide you a list of payers that do not currently have medical policies that outline the SOZO technology as experimental investigational. There are other various private insurance plans that are covered on a case-by-case basis. ImpediMed has partnered with MCRA for their patient access program as well as their payer engagement activities. We are working the top-down, bottom-up approach, have been successful in obtaining pre-authorizations, predeterminations, first and second level appeals for commercial payers that have negative policies that consider the SOZO technology experimental investigational. Those have been overturned on a case-by-case basis and provided coverage and payment for particular patients on a case-by-case basis. What should you do if your L-Dex claim is denied? There can be a variety of reasons why a claim is denied. First, it's important to understand why it was denied and what options are available in order to submit the appeal for the claim and or resubmit the original claim as appropriate. Again, ImpediMed has partnered with MCRA for a patient access program where they are able to assist you on a case-by-case basis for both pre-authorization and post-claim appeals. The Patient Access Program Overview is a complimentary service offered by ImpediMed. This program facilitates coverage through pre-authorization and appeals by submitting the appropriate data on a case-by-case basis. The program tracks the case requests and identifies trends in denials and also identifies evidence patterns. They manage all stages of pre-authorization and claim denial appeals, both internal and external, and in most cases, exhausting all appeal options. How will we work together to get this done with the patient access program? How to engage with MCRA to onboard your practice and or facility. This is an easy process. The physician office just needs to reach out to MCRA to initiate a case by sending a completed case intake form. It's one intake form per patient. In addition to the intake form, the practice would forward all clinical information pertaining to that particular patient. Our services include benefits verification. I'd like to call it benefits investigation, as we're finding out the level of appeals, co-pays, if your provider and facility are in network or out of network. We have pre-authorization assistance, peer-to-peer or a subspecialty review, internal appeals, and external and post-claim denial appeals. All cases that are submitted through the patient access program are forwarded to you every Friday in a report to give you the status of each individual case that you've submitted. Below, you'll see the designated patient access program support line, fax number, email, many different ways to get in touch with us. Primary case manager, her name is Laura Gullickson. She's been with MCRA for over 6 years and very dedicated on getting these cases overturned on a case-by-case basis. The coding reimbursement hotline is an easy access to a designated hotline telephone number. It's fast, real-time support. It's a live answer every single time. Hours of operation are 8:30 a.m. to 7 p.m. Eastern Standard Time. The coding hotline can assist you with Medicare national average payment rates for the 93702, assists with diagnoses codes, and ensures HIPAA and medical reimbursement compliance. The comprehensive coverage access support is where we respond to general coding and reimbursement questions. This is also where we prepare patient-specific letters that incorporates the clinical information that you provide to us into a pre-authorization and or appeal letter alongside the technology information. And that shows the medical necessity for that particular patient for that particular technology, in this case, the L-Dex technology. We are very cognizant of the payor guideline changes as we work closely with the payor engagement team on any changes to any medical policies. And we level set the patient and provider expectations as well as provide them with the timelines.
Thank you, Chelsey, for your presentation. I'm going to go ahead and switch over to Dr. Whitworth's presentation. So if the audience would just give me one moment. Dr. Whitworth, you can go ahead and come off of mute as well.
Good afternoon. I want to start with the big picture, economic picture, and then drill down to our practice pattern, because that really changes, I think, how folks have thought about implementing lymphedema prevention and bioimpedance spectroscopy. So let's start with the big picture here. First slide. Not many people know that we have prospective randomized level 1 evidence that clinical lymphedema can be prevented. This is a paper that was published about 10 years ago from a center in Madrid. Next slide. What they did was to randomize patients who had had axillary dissection, and it didn't take many patients to show this. 59 in the intervention arm, and 57 in the control arm. The intervention arm for this study for patients who had had axillary dissection was everyone in that intervention arm got physical therapy on a weekly basis, manual lymphatic drainage, progressive shoulder exercises. They didn't use compression garments, but they gave them manual lymphatic drainage. So essentially preemptive treatment for lymphedema. The control arm got education, but they did not get the physiotherapy weekly. The diagnosis of lymphedema was defined as 2 centimeters of swelling compared to the opposite arm. Next slide. The results were pretty striking. In the prevention group, only 7% of patients developed lymphedema. And in the control arm, 25% of patients developed lymphedema within a year. And these numbers are fairly compatible with what we could expect in any ordinary axillary dissection series. What happened here was a dramatic reduction of about 18% absolute reduction in lymphedema if they applied this physiotherapy to all patients. So here is, if someone has questioned whether we have evidence about this, here's the evidence. This is a prospective controlled randomized trial, statistically significant difference in preventing lymphedema. So I want to take the next slide and extrapolate a little bit and talk about what this means from an economic standpoint for a payer and an institution. So if you look at these results, 25% in the control arm and 7% in the prevention arm, that's an 18% reduction. And let's just extrapolate to 100 patients. What would happen if we treated 100 patients? Well, if this was an untargeted treatment, which it was in this study, you would treat 100 patients and you would benefit 18 of those 100 patients. You can see that just from the percentages above. But if you could identify those 25 patients out of 100 who really needed the intervention and target the treatment just to those patients, you would only have to treat 25 women to benefit 18 out of that 100 patients. Next slide. There's a little math involved here. So here is a publication from the Journal of Clinical Oncology looking at commercial payers. This is a very large proprietary database for commercial payers that looks at costs of cancer treatment, including lymphedema costs. And what this shows is that the 2-year demonstrated cost for lymphedema is $14,600. They looked at these patients who developed lymphedema and they subtracted out the costs that were related to their cancer treatment. And on a per patient basis over 2 years, lymphedema cost $14,600 additional dollars in management. Next slide. If you put those two pieces of information together, and this again is just the 50,000-foot view, in the first place, we recommend that patients get tested in the first 2 years every 3 months, every 6 months minimum, but every 3 months would be ideal. If you did that test every 3 months for 2 years and 100 patients at $125 per intervention or per test, it would be $100,000. Now, $125 was the reimbursement a couple of years ago. It's now $140, but I think you just save more if you look at these numbers. So the excess 2-year cost associated with lymphedema in 7 patients out of 100 versus 25 out of 100. So we're still using that example of 100 patients. If you add that additional $14,600 per patient over 2 years, if you use that with the 25 patients out of 100 who would get lymphedema, that would cost you $365,000. If you had that same cost, $14,600 in just 7 patients, in other words, if you eliminated an absolute 18%, that $14,600 per patient would be just $102,000. And that's a gross savings of $263,000 off the $365,000. But if you remember, we paid $100,000 in procedure costs. And so the net savings for 100 patients over 2 years is $163,000. And if you think about that on a per patient basis, it's about $1,630 per patient. 20,000 patients per year, that's a number that's appeared that develop lymphedema, would be a savings to the overall health system of about $32 million. But any individual institution or payer can figure out how many patients they're treating for lymphedema at any given time. The interesting thing here is that we almost never get a cost savings for medical interventions. Usually for a medical intervention, we pay something, and that's measured in a lot of cases by quality adjusted life years. And it's considered reasonable to pay $50,000 per quality adjusted life year. It's almost unheard of to save money in getting a better health outcome. Next slide. So if you're trying to make this argument with your institution or with a payer, it looks like a very easy argument to make, whether you're going for axillary dissection and reducing from 25% risk to 7% risk, or maybe you're just going for patients who've had a sentinel node biopsy and you're reducing from 7% risk to 3% risk. Or maybe you're talking about patients who have had neoadjuvant treatment and are getting an axillary dissection plus radiation treatment, and that would be a reduction from 50% to we don't know exactly what at this point. So here's the practical experience we've had implementing this in Nashville, and I'm going to just end with what we would recommend that any practice do or any system do. If you look at the year ending in September 2019, and I'm just going to take an example subscription on a per device basis. We have one device. If the subscription cost for that one device for a year or for a month is $1,500, that would be $18,000 per year. So that would be our cost basis. In the year ending September 2019, our reimbursement was $29,900, and you can see pretty easily that that covers our cost, and not only our cost, but the cost of the personnel who take about 30 seconds to a couple of minutes to do this test. In that particular year, we did 858 tests, and it was about 516 to break even. Not that we had huge reimbursement, and not that we didn't get denials, but to offer this service and to prevent lymphedema for those patients and still not lose money but generate revenue means to us that we have no choice but to offer this. For the year ending September 2020, considering the same subscription cost, our reimbursement was even higher, $37,900, close to $38,000 for 909 tests performed. And that just is because the reimbursement is improving all the time. CMS Medicare, if we were just billing Medicare patients, just doing this for Medicare patients, we'd only have to do somewhere in the neighborhood of 10 patients a month. And it's a lot more patients than that, of course. There are a lot of tricks to this because many institutions have tried to implement this. And when they get a denial, they're sending a patient a bill for $400. And that can only happen once or twice, and the patient won't even come back and see the doctor. So something has to be done so that patients do not get a surprise horrible bill, and so that patients really get this best care that, as you can see above, generates revenue even with a substantial number of denials as those are going forward. So the successful practices that we've had here started with, for a long period of time, we had easy access to physical therapy, and we would send every patient to physical therapy before and after their surgery, and every 3 to 6 months after that for at least 3 years, and sometimes for 5 years. And there were two forms, two advanced beneficiary notice forms, one for Medicare and one for commercial. And what we told patients was this: we're going to apply this to we're going to submit this to your insurance, and if insurance denies it, we're not going to really pursue that denial. We're simply going to send you a bill for $20, and that is all you're going to get charged for this. And there are a number of reasons why it's useful and helpful, and patients get this immediately. So that's what we've done for a long time. What we realized recently was that the workflow model for this needs to be modified. The workflow model that we think is going to be ideal, and that we think is ideal, is to simply place the SOZO device in the check-in area right next to the place where the patient has their weight done or their blood pressure, but the check-in vital signs area. And every patient who's had lymph node surgery or radiation is going to get this as part of their check-in. It's easy for those patients to be identified or flagged. And we are not going to chase these denials, except now that we have this very exciting program that you heard about a minute ago with MCRA, we are going to send those denials to them and let them handle that for us. But this way, patients don't get surprise bills. We're able to capture every patient as they come in. This is a very high volume event, and so we can't go through a pre-authorization process if we're going to use this as a check-in. On the other hand, in a physical therapy department, I'm sure that's something that would be considered. Our real model that we're recommending is to have this in the check-in area for the surgeon's office where the patient is coming in, or perhaps the radiation oncology office. But then that office is going to have a partnership or a collaboration with a physical therapy department, probably in the hospital. And so there will be a need for a device in that physical therapy department to monitor outcomes for those patients who are triggered with an increase in their L-Dex score in the check-in area. Those patients will be sent to physical therapy, where they'll also want a device to monitor progress and improvement. The main thing that happens here, the most important challenge, is for the physician advocate. If you want this in your practice, you're going to have a real heart-to-heart talk with your billers and administrators. They're not used to having a subscription model like this. They are not used to tolerating denials. It almost makes them need psychotherapy. They really, really have trouble if they're getting denials. They'll come to you and they'll say, we can't do this anymore. We're getting too many denials. Thankfully, there's a way that these denials can be handled outside the system, and they just need to be prepared that in the interim, before all the insurance companies are covering this, there will be denials, but the revenue is positive and the patients need the treatment. Thanks, Joanne.
Thank you, Dr. Whitworth. We will go ahead and open it up for Q&A now. So Chelsey, Dr. Whitworth, if you wouldn't mind joining me on video. And good to see the two of you. And we've already seen some questions come in. Thank you guys very much. Please go ahead. And if you have questions, please submit them through the Q&A icon on your screen. Chelsey went through a great presentation about CPT 93702, some of the details around billing practices. And then of course, Dr. Whitworth also gave you a good understanding of the benefits to patients as well as how he implements it in his practice. As more questions come in, I did want to, we are getting some questions about access to this presentation. I would like to let you know that this presentation and recording will be made available on the registration page where you signed up for this webinar within about 4 or 5 days from now. We will make it available. If you need information earlier than that, you can go to ImpediMed.com. You can go to the Healthcare Providers Lymphedema page, and you'll see a link to our reimbursement services. And you can view that and print it out, and it has all the information that Chelsey shared in a one-page document. So go ahead and visit ImpediMed.com, the Healthcare Provider Reimbursement page, or Lymphedema page, and you'll find the information there. So thanks guys for submitting these questions. Chelsey, I think let's go ahead and answer this question. We've had it a couple times. Some folks are asking, what is MCRA? They may have missed the start of the presentation. Would you mind just really quickly going over again, what is MCRA?
Sure. So we are a device manufacturing consulting firm. We offer not only reimbursement services, but we're a clinical CRO, regulatory, as well as compliance and quality assurance. It's really an integrated program one-stop shop, if you will, for our clients. For reimbursement, we specifically provide the patient access program and payer engagement activities with ImpediMed.
Chelsey, what does MCRA stand for?
Musculoskeletal Clinical Regulatory Advisors.
Okay.
A mouthful.
Good question.
Yeah.
So I have a couple of billing details questions. And then Dr. Whitworth, we've got a whole slew of questions here for you. So Chelsey, we just have a couple questions about setting. One is about what is the billing situation in a radiation center? And what is the billing situation in an occupational therapy office? Could you speak to those two settings?
Yeah, sure. So I haven't, that's a great question about the radiation center. I haven't received that to date. So that's a great question, and I can connect with them offline. If you can provide that contact information, I'll have my team look into it for them and provide them rates and such and contracting issues. Physical therapy, occupational therapy, you know, the physical therapist can perform the test in individual physical therapy site. You can connect with the Medicare administrative contractor to see if they can bill out that particular CPT code. But most commonly that cannot be billed for a regular physical therapy facility. However, they can perform the test.
Thank you. And I think one other question about your patient access program. I have a question about sharing personal health information with MCRA. What sort of agreement is needed between the practice and MCRA in order to participate?
Great. And I have Colleen Nelson, my Vice President of Compliance, on here to explain that. Colleen, can you connect with her, Joanne?
It looks like Colleen is not available on the microphone. I don't see that she has audio access right now.
Okay, so yes, that's a great question about the business associate agreement. Best practices, obviously, if you're sharing PHI, we can definitely engage with you with a business associate agreement. I was going to have Colleen speak a little bit in greater detail. We have a business associate agreement that we can provide to the facility and or physician practice just to review and sign and send back. MCRA's best practices, we are obviously HIPAA compliant workflows, and I wish she could speak to it a little bit more since she's our compliance officer in greater detail. But we do have a business associate agreement.
Thank you.
And that works in our practice very well, just like your relationship with your electronic medical record provider, or in the old days, your dictation company. Those are very commonplace for programs and companies that support your medical practice, but you just have to have a business associate agreement. In our EMR, I'm hoping to give MCRA even a little more access to segmented portions of our EMR, which we do with some vendors, so that they can get some clinical information if they need it without us having to touch it. But we'll see what happens as we move forward with that.
Thanks, Dr. Whitworth. And we're getting a lot of questions here for you. So I'm going to try and go through them and group them as much as possible. So just a couple questions about your model. So they're just asking you to confirm the process here. Insurance is billed, a patient signs an advance beneficiary notice, and the patient only pays $20 if the claim is denied. Can you confirm that's correct, and whether you attempt to obtain prior authorizations?
Yeah, that's been a very effective model for us. This is a high volume event, so it would be like getting a pre-authorization for weighing the patient as they check in. It just wouldn't make any sense for us to do that. I think it would make sense for a physical therapy department to do that, because those are a little more planned and regimented and focused visits. But we don't want to miss these patients who need to be tested. So we see a lot of patients who have had lymph node surgery or lymph node radiation. And so we want to test every one of those patients. And the only way to do that is in a sort of a high workflow setting, which in our analysis is best done as part of the check-in. There are several physicians around the country who've done that for a long time. And so they weigh the position, they weigh the patient, they stand them on the SOZO machine, and it takes about 30 seconds to get the reading, and the patient is on to see the doctor. If the reading is above 7, if the L-Dex delta is above 7, that triggers an intervention. And what they do, I think we might have had a little glitch there. That triggers an intervention, and what that patient does then is the physician sends that patient to the physical therapy department, and they put a sleeve on that patient for 30 days. And that's it. That intervention for patients who have an increase in their L-Dex, but no swelling in their arm, appears to gives us that level of prevention, so that we have a dramatic reduction in the number of patients who go on to swelling that requires complex decongestant therapy. So that 1 month intervention with compression, with a sleeve that can be fitted to the patient, can be done in the physical therapy department. So the physician's office doesn't really have to manage that. All the physician office does is identify that increase in the L-Dex score. That's part of the L-Dex electronic platform. So it's easy to identify. The pad that the medical assistant is using is going to report out this patient has gone up 7 points, and this is a triggering event, and she needs to go to the physical therapy department. But that workflow works very well. Now, frankly, I don't think we need to even charge $20 for a denial. We just need to be able to promise the patient, if it is denied, we are not going to charge them anything. And we would still end up in a revenue positive situation. Now that we have this relationship with MCRA, that's not even a problem. Those denials would go through that process. So I think that we're only going to see that positive revenue improve. And the key for me is we're providing a service that patients really need. One of the second or third questions patients ask us is about lymphedema. They want to know if they're going to live, they want to know if they're going to get chemotherapy, and they want to know if they're going to get lymphedema and how we're going to prevent that.
Thank you. And we have some questions about your program, Dr. Whitworth. How often do you monitor patients following their treatment? And then how often do you recommend physical therapists monitor patients?
We follow our patients up, our cancer patients, and that's who these patients are. We follow those patients up for many years. We followed them every 3 months for a couple of years, then every 6 months, and then every year. Some of those patients we've gone to every 6 months. The experience we have, the biggest experience we have with SOZO with bioimpedance measurements is every 3 months for the first 2 years. And when we do that every 3 months for the first 2 years for those patients, we've seen our risk for lymphedema in high-risk patients who've just had sentinel nodes. And by high risk, I mean patients who've had taxanes or overweight or have another risk factor. That risk has dropped more than half in patients where we've used this approach. But it's a very high volume event. You either need to send everybody to physical therapy. We have a physical therapist in our office. Most offices don't have that. But the successful practices using this right now are putting it in their intake area. And if a patient's had lymph node surgery or radiation, then she gets SOZO on the way in the door.
We have a couple questions about your employment of a physical therapist in your office. Can you speak a little bit about that and what the therapist does at a part of your practice and how your therapist is integrated?
Yes, I mean, I don't think this is a requirement for this. In fact, it's just something we've done for a long time because we're a dedicated breast-only practice. So we have a very high volume of breast patients. It is a fact that breast cancer patients who are about to have lymph node surgery or lymph node radiation are covered for a physical therapy evaluation, a formal physical therapy evaluation by Medicare and by other payers. So we believe those patients should all have a physical therapy evaluation before surgery and after surgery, and should have these evaluations on a regular basis afterwards. So we implemented that in our practice just based on the fact that we have a high enough volume to support that. And frankly, it is very nice when patients say, I'm having this problem or that problem. And we're in a position to say, well, you need to see Andrea. She can help you take care of that. So that's just a nice thing. If you have a very high volume breast practice, that person could be in the area or right next door. I think in most practices out there, the surgeon's office will be separated by a little more distance, and they'll really want a collaboration, a relationship with a good physical therapy department in the hospital or nearby, where they can send patients if the patients trigger, have a triggering event, which means basically their L-Dex score went up by 7 to 10.
Thank you. Let's talk a little bit more about the patient access program. Dr. Whitworth, you said you're going to participate, which is great. And Chelsey, we have a question here of whether the patient access program process is done prior to or after the SOZO testing is done. So how does it work with regard to when the SOZO test takes place?
That's a great question. So you can submit the case at any point in time that you wish. You can send it when you know that you're going to have a patient coming in for their initial assessment. You can send a denied claim in post the initial procedure, any point in time. For pre-authorization or predetermination, if you've already received a pre-authorization denial, you can send that in and we can work the internal appeals process at that point in time. So it's really up to the practice or facility when they submit it to us.
Thank you. Another question back to you, Dr. Whitworth. We, actually, this is probably for MCRA, I apologize. This question is, this participant has their own in-house accounts receivable team who does appealing for SOZO claims. Can you offer them some kind of training on how to properly appeal SOZO denials?
We can most definitely walk them through. So, the whole purpose of this program is to show demand for the technology, because obviously there's a lot of commercial payers that have negative coverage decisions. And that's why ImpediMed has partnered with us to overturn those negative medical policies. So we have developed template letters, if you will, for pre-authorization that incorporates the SOZO technology information along with the patient's clinical information. Those template letters, of course, are available. We can forward them over to the individual practice or facility. I can walk them through how we do our best practices. Anything to get the technology covered for the patients, that's our goal.
Joanne, I can tell you that this person who's asking this question, who has in-house accounts receivable and billing and folks that work denials, that's a very tricky thing, because most of the time, if you do something either in terms of the physician's time or a device like a disposable, if you're doing a biopsy and you do a service and it doesn't get paid, it gets denied, you lose money. You're actually losing the cost of whatever that time was or that device was. This procedure, this test takes about 30 seconds, and you're really not losing anything if it gets denied, at least not a big number, maybe a minute or two of a medical assistant's time. But when you look at the overall, and our experience that I showed you earlier backs this up, applying it to everyone and just accepting a number of denials at this point, it's revenue positive. Working with MCRA, I think that's going to be a lot less of a problem. But your biller that you work with in your office is going to go crazy. They are really going to be upset. Billers and coders and folks that work denials cannot stand denials, and they will come to you and say, we can't do this anymore. We're getting 50% denials. We just can't do it. It's ruining us. And so you'll have to have a talk with them and explain to them, this is what we're going to do for a while. It's revenue positive. We can get you trained and working with the MCRA group if you need that.
Thank you. And we have some questions about how much time. I mean, based on your experience, Chelsey, working with practices, how much time on the part of the practice is required to participate in the patient access program?
All they have to do is submit a simple intake form. Once we have the physician's information, their NPI, tax ID, I make them a master intake form. So then they just have to forward over the specific patient's demographics and insurance information along with the clinical information. So that technically should depending upon the office, maybe take 15 minutes per patient. We take it from there. That's when we develop all of the pre-authorization and or appeal letters. We already have the clinical information that we're also using with our payer engagement activities. So we're doing the top-down bottom up approach and aligning the messages, key messaging with both departments. But really, it's a very minimal amount of time for submitting the case information to us. We do the majority of the legwork. We're on checking the case status for the pre-authorization. We're trying to expedite it as much as we possibly can. For the appeals can be anywhere from 3 to 30 days. But our team, we're contacting the insurance company. We're demanding that they review. We're demanding that they have a specialized medical director reviewing these individual cases, as it's payer specific for timing as well.
Thank you. And I'd like to reiterate for those on the call. Yeah, we do have the appeals letters that Chelsey was describing available. If you want to get in touch with MCRA or you want access to this information, there's a couple different ways to do it. For any of you asking questions on this call, we have your contact information. We will reach out to you individually. And you and anyone else can go to ImpediMed.com, go to the healthcare professionals section lymphedema page, and find the reimbursement services link. You can download and print our one-page PDF that has MCRA's contact information and a lot of the information that we're discussing here. Also, you can contact your local ImpediMed representative, and they have all of the contact information for MCRA and could get you access to that information. So a lot of different ways to access, and if you want us to contact you directly and you're on this call, ask a question, say, hey, just please reach out to me, and we will be sure to put you on that outreach list. So a couple more questions coming through. So Chelsey, we need some clarification, please. I'm getting some questions back about someone who is in a PT/OT outpatient facility. So they're not necessarily part of the physician's office or hospital. When they're an independent facility, what is the reimbursement? Could you revisit that reimbursement process?
Yeah, so if they are outside a physician, there's no physician within that facility, they can contact Medicare, their Medicare jurisdiction, because this is not a therapy code. 93702 is not a therapy code. So they would have to contract Medicare to see if they could put it on their list of approved services.
Okay, and is that something MCRA can help with?
I can definitely walk them through on how to do it for their contracting.
Okay, excellent. So if you need help, if you're an independent physical therapy practice, you need help making sure that this is a covered procedure for you, the ImpediMed and MCRA team can certainly help you with that process. So another question about the patient access program process. How long does it typically take to get paid for CPT 93702 from insurance companies, including the time for appealing denials? So what does that time frame typically look like for someone who would want to participate?
So from start to finish, for an individual case, it's payer specific, and I hate saying that. I can give you an example. We received a pre-authorization case November 1st. This is best case scenario. On November 1st, we received this case. The pre-authorization was denied within 24 hours. Normally, pre-authorizations can take anywhere from 3 to 10 days, but we received it within 24 hours. We denied that, and this was a Medicare Aetna, so it's a Medicare Advantage case. We denied that first a level appeal, and we received an overturned appeal within 8 days. That is the best case scenario. Normally, pre-authorizations, again, 3 to 10 days, a first level appeal. Since it is considered experimental investigation with most commercial policies, first level appeal is anywhere from 3 to 30 days. Then you have a second level appeal, depending upon the member's plan. That's another 3 to 30 days. If all of those appeal options still have been denied, there's a chance for an external review and or an independent review. So all in all, for an individual case, for the pre-authorization process, it can take upwards of 3.5 months.
And tell me again, what is the role MCRA plays in that versus what is the role that the practice plays?
We do everything and keep the practice updated on a weekly basis based on all of the cases they submit. We send them a nice report every Friday just to let them know the case statuses.
Okay, thank you. Dr. Whitworth, we're getting some questions about your model. So one of the questions here is, does your model that you outlined suggest that you charge $140 per patient until 18,000 is reached? For example, you cover the cost of your subscription, and then every time after, the patient is charged $20 for follow-ups? Could you describe again how that works? And I think you're on mute.
I included that as an example, just in terms of how many you would have to do to break even. We do this for every patient. We don't pursue a pre-authorization because it's patients coming in through intake. It would not work out to take that much time. We do like the idea of sending denials over to MCRA, but we don't pre-authorize these folks. We test every patient. We expect a large number of denials. We bill every patient. We bill every insurance. And we tell patients if they're denied, if you're using the intake model, you could have those advanced beneficiary notices there, but we don't really intend to do that. We don't think they're going to need that $20 from the patient. Many insurance companies, not all, but many insurance companies are paying $200, $300, $400 for this now. It's a minority, but again, with that payer mix, in other words, the commercial plus Medicare, we're averaging well over what we need to break even, just doing this for the patients that need it, but doing it for everyone. And it drives the billers a little crazy and the people that work the denials a little crazy, because we tell them, yes, there are going to be a lot of denials, but we are generating positive revenue and we're doing something that the patients really want and need. And frankly, we really want and need it because we don't want to have to be saying, I'm so sorry you have lymphedema.
Excellent point. Chelsey, we're getting a couple more questions about the process here. Have you ever had patients contact MCRA? And you're on mute, Chelsey.
Thanks, Joanne. Yes, we have. We can work with the patients individually as well.
And as far as the pre-authorizations, do you get a single pre-authorization for the full year of tests, or do you do it once every 3 months? How does that work?
It's up to the particular provider. We best practices is we try to get a pre-authorization for 4 visits, which would take up the whole year if you're doing a testing every 3 months. So we request 4 visits. Okay.
Thank you. And another question for you again, Dr. Whitworth. I know this is a little bit back and forth, but it's how the questions are rolling in, so apologies. But if you do an advanced beneficiary notice and the claim is denied and you charge the patient $20, and then down the road you receive money from the insurer, how do you handle that?
That's a great question. That actually happens with everything we do. We occasionally get paid by the patient, and then there is a payment that we didn't expect or that hadn't happened, or the denial gets reversed. And that's if you go talk to your billers and coders, they'll say, oh yeah, that's this refunds column. So the patients would get a refund if we got paid, unless it's part of their deductible. Yeah.
Okay, thank you. Thank you. Well, I think that is wrapping up the questions that we have. So I think, thank you both, Chelsey and Dr. Whitworth. This is really a fantastic webinar, as you can see by the number of participants and questions we had. A lot of interest in this topic and really appreciate your participation. We do have additional webinars coming up in December. We have our SOZO user group where we're going to do case review and discussion on how to get the best out of your SOZO device. That will be moderated by Maureen Macbeth. And in January, we have Karen Hoke and Kari Utendorf from The Ohio State University talking about the prehabilitation model of care. That's that model of having your breast cancer patients see the therapist prior to any treatment beginning in order to start their survivorship plan. So look out for registrations for our upcoming webinars, and thank you for your participation today.
Thanks, Joanne.
Thanks, Joanne.
Thank you, guys.